Now, in this section, we will keep talking about the dysmenorrhea, but we will talk about mainly what are the clinical features of primary dysmenorrhea, how the patient with primary dysmenorrhea present, how we can treat and manage the primary dysmenorrhea. So clinical features of primary dysmenorrhea, usually again they are more in the adolescence girl, especially when they have the beginning of the menstrual cycle. Usually these are the patients or these are the girls who present with dysmenorrhea or primary dysmenorrhea. Begin within few hours before or just with the onset of menstruation. It's very common people who have dysmenorrhea that they usually get the indication that cycle is coming because they have lower abdominal discomfort usually a day before the bleeding starts. So it's before few hours before or like a day before, and then it continues after the menstruation for about 24 to 48 hours. That's the time when it's maximum. May extend up to 24 hours. Spasmodic pain and is confined to lower abdomen. Usually the pain is lower abdominal pain, and some patients also have systemic discomfort with this, which includes usually they have nausea and vomiting. Lot of patients with primary dysmenorrhea, they present with nausea and vomiting. Symptoms: nausea, vomiting, fatigue, headache, diarrhea, tachycardia or fast heartbeat is common. And then there is also cold sweats, fainting, pallor. So all these are the systemic symptoms of the patient with primary dysmenorrhea. So they have headache, fatigue, nausea, vomiting. Lot of people really have a bad headaches with the onset of menstrual cycles, which are labeled as the migraines. So every month when they have menstrual cycle, they get migraines, and migraines are usually associated also with nausea and vomiting. Treatment of primary dysmenorrhea is general measures are important. Assurance of the patient that it will get better, and then some improvement of general health and psychotherapy. And then drugs are sometimes used like prostaglandin synthetase inhibitors. So as I mentioned, prostaglandin is the main factor that leads to pain. So prostaglandin synthetase inhibitors are used. Then also oral contraceptives, non-steroid anti-inflammatory drugs, which are analgesics for pain, then smooth muscle relaxant glyceryl trinitrate is used. Oral contraceptive pills and dihydrogesterone is used. Then surgery, laparoscopic uterine nerve ablation, especially if it's very bad, this can be tried. And laparoscopic presacral neurectomy. Dilation of cervical canal, sometimes it helps if the canal is narrow or small, or if there is stenosis, dilation can help improving the dysmenorrhea. So all these measures can be tried. We have psychotherapy in which we reassure the patient that it will get better. Maybe don't use too many medicines. It takes time and it will get better, things like that. And then the drug therapy is oral contraceptives, non-steroid anti-inflammatory drugs are mostly used, and prostaglandin synthetase inhibitors. And then we have some surgical options also for the treatment of primary dysmenorrhea. Next, management of primary dysmenorrhea. Management is first we have assurance, then analgesics and antispasmodic drugs are used, and then encourage the normal activities. Try to explain the patient that it will get better, and then you should have your normal routine as much as possible. So this is the first line of treatment: assurance and encouragement and use of basic analgesics and antispasmodic. If this line of management or treatment fails, and if it's not helping the patient, then we should have followed the two lines mainly. In the first line, if there is no contraindication for prostaglandin synthetase inhibitors, and in the presence of contraindication of pill or patient wanting pregnancy. So in this condition, we use prostaglandin synthetase inhibitors for 3 to 6 cycles. The other patients are the patients who have contraindications for prostaglandin synthetase inhibitors, but they have no contraindication for pills. In these patients, we use pills. And in patients who have no contraindications for both these drugs, we can try both of them. But if these medications fail, then the choice is only there is ultrasonography, laparoscopy is used to exclude any pelvic pathology. Then we can try surgical measures like dilation of cervix, laparoscopy, and then uterine nerve ablation and presacral neurectomy. So first line is to assure the patient and use simple analgesic drugs. And then if this fails, then we go for two methods. One is the patients who have contraindications for prostaglandin synthetase inhibitors. We use oral contraceptives. In those who have contraindications for oral contraceptives, we use prostaglandin synthetase inhibitors. In patients who have no contraindications for any drug, we can try both depending on the priorities of the patient. If all these fail, then we should go for surgical measures, which include laparoscopy, dilation of the cervix, uterine nerve ablation, and presacral neurectomy, which is rare but can be tried. So that was all about the clinical symptoms, treatment, and management of dysmenorrhea. Thank you for watching sqadia.com.